So welcome everybody. I'm Alan Roth and I am a practicing family doc. I'm chair of family medicine in Queens, New York, and a proud member of the board for primary care for all Americans. On behalf of all of us, I'd like to welcome you to today's Teach and Learn In Zoom session. Thank you for joining us this evening. Tonight is a warm-up for getting us ready for our first annual summit on May 20th in Cambridge, Massachusetts. So where 100 people from across the country will gather to keep building our movement to provide primary care to everyone in the U.S., in every neighborhood, every community. A link to this information to the conference's chat room, so please go there and join us. There's only a few openings left. We'd love to sell it out. It would be great for our first convening. It's now my great pleasure to introduce our moderator for this evening, Catherine McDaniel, and extend my sincere thanks to all of the presenters for tonight's event. I'd like to thank the Primary Care for All Americans Zoom Committee, as well as John Wright, Patty Armstrong, and Liv Varetti for organizing today's event. Take it away, Catherine.
My name is Catherine McDaniel. I'm a former student of Alan Sager's, now practicing family medicine with obstetrics in Cambridge, Massachusetts. I want to start by thanking you all for being here tonight. By joining us, you're helping to build a movement, one that focuses on providing healthcare to people in every neighborhood and community, primary care for all Americans. Please add your name and location in the chat and maybe a flower that you've seen blooming recently if you didn't get a chance to share before. As a quick reminder, we don't use professional titles here. This space is about working together and valuing the ideas and commitments that will drive this movement forward. Now it's my great pleasure to introduce our keynote speaker, Dr. Alan Sager. Alan Sager is a professor of health law, policy, and management at the Boston University School of Public Health, where he has taught finance and planning for 86 semesters. I took it in his 84th. He is writing a book called The Easiest, Affordable High-Quality Healthcare for All is the Easiest Problem to Solve in the U.S. It aims to serve as an insurance policy that would pay off if our nation suffers a healthcare crisis. The book describes feasible interlocking reforms in financial coverage, cost control, primary care, hospital financing, long-term care, and meds. Alan Sager has designed a time-banking method of mobilizing voluntary aid for disabled citizens by creating a structured, parallel economy of good deeds. His analyses of urban hospital closings over 85 years found that closings harmed access while boosting costs. He has his BA in economics from Brandeis, and his Ph.D. in city planning is from MIT. Take it away, Alan Sager.
Catherine, thank you very much. As you know, I ordinarily teach for 3 hours at a time, and I don't think we have really that long tonight, so the jokes have to go. But let's start with a quiz. I'm thinking of 3 big numbers, and I'm trying to share screen, and it's not letting me do that. Any help
John,
on
can you
sharing
help?
the screen?
Let's try one more time. Let me check and uncheck the box and go for it again.
Okay. Thank you. Okay. So we'll do this without the visuals. I'd like you to imagine 3 big numbers. All 3 have lots of zeros at the end. The 3 numbers are in a ratio of 1 to 2 to 6. So which one is all healthcare spending in the United States, which is all defense spending, and which is all education spending, public-private, K through as high as you go. So 1 is, and 2 is, and 6.
Education and healthcare.
Defense.
Okay. Well, as it turns out, 2 is education, 1 is defense, and 6 is healthcare. So a number of you got that. Most people don't. So I'm suggesting for the title of this brief talk that primary care is the critical path to affordable health care for all. The critical path is if you're doing anything complicated, a lot of tasks have to be accomplished. The critical path is the task that takes the longest. And training a family physician, a primary care physician, takes longer than building a hospital. So it's the reform element that takes the most time. And I'd like to talk mostly about top-down approaches to financing and training and paying primary care physicians to complement the bottom-up community-level approaches. I don't need to say much to you all about the value of primary care in improving access, in containing costs, assuring people the right care, and in building trust in healthcare on the foundation of a trusting, durable, long-term relation between you and patient. So if primary care is so important, why has it been so neglected? You know most of the reasons. Starting in the 1940s, 50s, 60s, teaching hospitals decided which residents to train, and they disproportionately trained the residents they wanted to provide low-cost care in the hospital. They had no eye on the nation's need downstream for the doctors they trained. Usual, customary, and reasonable fee for service, boosted pay for physicians who perform procedures. The country as a whole is uninterested in equity of access to care, containing costs, having the right caregivers in the right places, or establishing a solid floor under quality, appropriateness, and competence of care. Also, people who make decisions in our country have untrammeled access to primary care. They're not worried, though their kids are. Also, anarchy pervades healthcare. We don't have a functioning free market, nor do we have competent government action. Without either a functioning competitive market or competent government, we have anarchy. And sometimes people say, well, government regulates, but really what government does in healthcare is a job that parallels the job of the guy with the bucket and the barrow and the shovel who follows the circus parade. Instead of serious action on primary care, we rely on gimmicks, things with names like patient-centered medical homes, free tuition, if you work in primary care, and the like. Many of these things are good, but they're, I call them gimmicks because they deal with tiny shares of the problem. We need to move up from anarchy. There may be no effective political or financial support for primary care for all Americans today, but the looming healthcare crisis will change that. I think within 5 years, we'll see something that most of us would regard as a meltdown of healthcare. Wholesale caregiver bankruptcies, far exceeding what we see today, along with even greater denials of access to needed care. What would cause a crisis? The hollowing out of the economy, high deficit and interest costs. This year, interest costs exceed defense spending. In 5 years, they could be double defense spending. International challenges, social disruptions, 2 dysfunctional political parties. And of course, the French, always more competitive, have 3 dysfunctional political parties, and nobody can count how many the British do. In addition, a major source of the healthcare crisis is not these things outside healthcare, but the breakdowns inside healthcare itself. $1 trillion rise in healthcare spending in the last 3 years alone. Inability to boost spending not only to cover more people, but we are not willing and able to boost spending to protect coverage for people who have gotten it under ACA and elsewhere. The absence of effective cost controls. The only cost controls essentially that work in the United States today are the ones that function by suppressing access to care. We also have caregiver addiction in most quarters to more money for business as usual, and reliance on financial incentives to bribe doctors and hospitals and others to behave differently, instead of relying on financial neutrality, budgets and adequate revenue, altruism, and fiduciary duty. So if this materializes and we see at the bottom of the next recession, Congress may well freeze federal spending on healthcare, on Medicare, federal Medicaid dollars, VA, ACA subsidies. In response, doctors, hospitals, drug makers, nursing homes will try to boost payments they get, prices they get from privately insured patients. But that would assume that drug makers are leaving money on the table today, which I doubt. And with family premiums today at $30,000 a year nationally, and probably approaching $35,000 or $38,000 at the end of this decade, employers are not going to say cheerfully, yes, we'll make up for the freeze in federal healthcare spending. Fortunately or unfortunately, waste inside healthcare is half of healthcare spending. So that's $3 trillion in fat out of $6 trillion in total spending. Clinical waste is probably the biggest. Care that doesn't work, care that patient doesn't need, high price, low value care, the meds that extend life by weeks for 5 or 6 figures. Administrative waste, approaching $1 trillion a year. High prices for meds, many salaries, devices. Also theft. Theft is the smallest, but at 5% of healthcare spending, we're looking at $300 billion a year. Now, these 4 types of waste, mostly unintended, in ways not intended, have become baked into U.S. healthcare. Each of the 4 types requires its own remedies. Adequate primary care for all is the best tool to address clinical waste and to reassure patients about whether we and they will get the right care during the years of reform that respond to the financial crisis and the medical crisis and the coverage crisis that we can see coming. Now, crisis may generate political and financial and human impetus, pressure to squeeze out the fat, but seizing that opportunity requires preparation. That preparation is not happening. As you know, healthcare is complicated. Recycling fat into clinical bone and muscle is doubly complicated. Reform's success will rest heavily on having the right numbers of caregivers and the right types of caregivers, especially in primary care, covering the nation. So, primary care for all will be essential to win reformed and affordable health care for all. Primary care is the critical path because it takes the longest to realize. The US, across all rich democracies, is 3rd lowest in doctor to population ratio. And we suffer a low percentage of those small numbers of doctors working in primary care. Even though we now train 30,000 new medical school and osteopathic school graduates a year, diverting a bigger percentage of them into primary care will be hard. Teaching hospitals are understandably addicted to low-wage residents to help sustain their medical care. So if we want to train more people in primary care, one of the steps will be to increase medical school and osteopathic school graduates by at least 10,000 a year, a 1/3 increase. That's daunting. Now, primary care residencies cry out for expansion, but I would suggest that more and more of this should happen inside of existing groups, small groups of primary care physicians. So one possibility would be after PGY1 to embed primary care residents more and more until overwhelmingly they work in physician groups, diagnosing and treating their share of patients each day under supervision of a skilled mentor who would review diagnosis and treatment decisions of all patients at the end of the day and would be available for hallway consultations. Residents would bill for their services, and that would probably mean a tripling of PGY2 primary care physicians' incomes over what they are today. And the mentors, many of them might be paid separately. Many of them could be great primary care physicians lured out of retirement, the way the French have done to meet gaps in primary care. The money matters. I think we don't have a functioning free market anywhere in healthcare, but there's still such a thing as a market clearing price. We can either draft people into primary care like they do in much of South America. I don't think that'll fly politically. The alternative then is money. And there is a market clearing price that would help attract more and more good physicians into primary care. And I think that market clearing price would be in the range of 400 to 500,000 a year. At the same time, we need to pay attention to the conditions of practice. Paperwork associated with payment that stems from mistrust between payers and doctors can and must be slashed. At the same time, that reduced paperwork and reduced pajama time would free up time in the lives of primary care physicians. I think it makes sense to drop panel size to 1,000, depending on age and illness and case mix, but an average of about 1,000. So we'd need 340,000 full-time equivalent primaries for 340 million Americans. The arithmetic isn't hard. And the good news is paying 340,000 primaries, 400 to 500,000 each, plus fringes, only takes about 3 or 4% of healthcare spending. It's a good deal. With small panel size, primary care physicians have time to make appointments long enough to learn patient needs and build trust, see patients same day, next day, converse with patients by phone and email when appropriate, follow patients into the hospital to coordinate care with specialists, take time to learn about unfamiliar problems, and the rest. Time to breathe. Now, the conundrum is a challenging one. The crisis I've described in healthcare, the bankruptcies, the inadequate revenue, and the need to aggressively go after the half of healthcare spending that's wasted on clinical waste, administrative waste, high prices, and theft. The crisis will provide an impetus to go after that waste, and it'll mean more support for finding primary care physicians. But at the same time, having greater primary care capacity in place before the crisis hits will be vital to weathering the crisis, to squeezing out waste, to stabilizing care, and to reassuring patients who legitimately would fear that they'd be vulnerable to deprivation of needed care during the crisis. Primary care could be essential to help squeeze out fat, to stabilize healthcare, to get that bone and muscle, to stabilize healthcare. During the crisis, at a time when everybody's nervous, people are impatient, and critics will be carping from the sidelines. Now, even in a crisis, it'll take time to ramp up primary care capacity because we're unlikely to begin soon. So in the short run, what do we do? Well, nurse practitioners are one option. Many people talk about that. Also, preparing nurse practitioners and PGY2s and 3s to take on established, more stable patients in primary care, and bringing in experienced primary caregivers, physicians, to coordinate care for the costly and complex patients. We know that 1% of patients absorb a fifth to a quarter of the cost, and 5% of Americans absorb half of all healthcare costs. So if we could entice 5,000 newly retired good primary care physicians to take on 500 costly, complex patients each, they'd handle 2.5 million Americans. The folks who are complex and expensive to serve. More will be needed. That's a start. I see these top-down approaches as ways of complementing the vital community level, bottom-up building support politically and financially for primary care. I think the two pieces reinforce each other, and I think both are essential. So I hope those thoughts are useful, and thanks for bearing with me during the technologically challenged inability to share a screen.
Alan, thank you so much for sharing with us and giving us a lot to process through. We do want to open the floor to questions. If you have a question that you would like to share, drop it in the chat. We will get to those in just a minute. While we are getting started, Alan, I really appreciated sort of this look is a different approach than what we've talked about in some of our previous discussions. We've looked a lot at the community-based organizations, and we've talked about direct primary care, concierge practice, and all of these different elements are needed. But in this particular approach, as we look at more healthcare physicians moving into direct primary care or concierge practice. I'm really struggling with that word tonight. What impact on healthcare costs, and how quickly will those costs turn into higher premiums for families and employers?
Well, one of the things we know is that if a primary care physician who's done this for 5 or 10 years and has gotten a lot of experience and has 2,500 patients and goes concierge with 500 patients, paying them $10,000 each, that's a lot of money. Paid privately, almost all paid privately, and they abandon 2,000 of their patients. Which means bigger panels for physicians remaining in primary care, more pressure to rely on nurse practitioners, and the small share of PAs who work in primary care. And you can tell a story that people who lose primary care delay care, and that may drive up costs, or it may mean that people become late without having gotten the care they needed, which saves money, not under good circumstances. We know that since we're not going to draft physicians, we have to make primary care attractive and personally satisfying from day to day for primary care physicians. And I think easing on the paperwork, reducing panel size, and doubling incomes would go a long way toward doing that, as well as restoring primary care physicians powerful places in the lives of patients, and especially at the times of health crises, which can entail hospitalization. I think reintegration of primary care into the hospital with primary care physicians, again, having lunch with other physicians and rebuilding that community and knowing which cardiologists or which orthopods to refer to would be just invaluable.
Yeah, I think the approach that you're talking about, I appreciated you framing it in a top-down approach. It had a lot of echoes for me to my years in manufacturing, right? The world-class manufacturing world where you do your benefit cost analysis, and that is really what helps you decide what to attack for waste, right? And then you do a targeted approach based off of your highest waste, right? And this is exactly what you're applying, sharing these same economic sort of values in here. So as we look at that, what are the three most important, and I would say, like, what are the three actionable things, right? Sometimes waste is just in existence because that's how life happens, and we know that there's always going to be human error. There's always going to be paperwork mistakes or, some things. But in terms of what is actionable, what are things that, like, in our communities, should they do their own benefit cost analysis? And then how do they approach those next steps?
I think it's very hard. One of the things that happened in the state of Maryland was that because some hospitals were going broke because they served more uninsured patients in the 1960s, 1970s, the state lurched toward all payer, where all payers paid the same price, and every hospital was guaranteed revenue sufficient to finance efficient delivery of needed care. And they've gone now toward consolidated budgets, which means that if they save money on inpatient care, they can hire more primary care physicians. So that's an approach that's statewide, all payer, no reason for hospitals to discriminate against Medicaid patients or even uninsured patients. And you've got that local budget that's available to hire primary care physicians. It doesn't train more, and it doesn't raise incomes. Even a system like Mass General Brigham here in Boston, with close to $20 billion in the bank, faces unionization and looming strikes by primary care physicians who are treated badly overall by the system and who are underpaid by every reasonable standard. But even with 20 billion, whatever local pressure they're susceptible to hasn't been enough to get them to clean up their act. The head of the hospital makes enough at today's level, at today's income, to pay 25 primary care physicians. to care for 50,000 patients.
Yeah, those are the things that, yeah. So Bill sort of hit on this a little bit in his question in the chat, which is, why haven't businesses, small, large, revolted against healthcare costs for their employees? What is that tipping point? What is delaying that tipping point? Like when will enough be enough?
Well, most healthcare executives most business executives think about their healthcare costs as something for HR. They don't know anything about healthcare. And the HR people solicit bids from different insurers who all face the same doctors and hospitals. And when an insurance company or tries to exclude costly hospitals, they have big problems, big political problems. And also the other thing is most employers work in what they think of as a competitive free market. And these employers break out in sweats and chills of free market thinking, kind of like malaria. And that prevents them from seeing healthcare realities clearly. So they tend to favor remedies like breaking up insurance company monopolies or going after multi-hospital mergers to try to break them up, or give patients information about price so they can fly like kamikaze pilots in a cost control war. No generals and admirals flew kamikaze planes. So they're ideologically challenged, and they're ignorant about healthcare realities, and that's a toxic combination.
I would tend to agree for sure. One question that Catherine actually sent in as well is about how do we get to the point where PGY2 and PGY3s, to be fair, I had to Google what that meant. Those are the junior and senior resident physician years, I realized, could be embedded into primary care practices and billing. How much would the federal government need to sign off on versus how much could be done at the state level? Where does the legality and sort of the policy come into play with that theory?
Well, to be licensed as a physician in most states, if I recall correctly, you need medical or osteopathic school graduation and the first year of residency. You're licensed as a physician. You can go out and commit primary care and bill for it. And indeed, when a physician works, when a PGY 2 or 3 works in a hospital continuity clinic or urgent care center under the hospital license, the hospital bills for the doctor's services and gets paid for it. The resident doesn't see much of that money.
Yeah. No, it does become a game a little bit at times, it feels like, with figuring out where exactly things land. And I think just to pick up one more question from Judith before we pass it back over to Michael is, how do we make these things happen? You've got a group here that's very active, wanting to participate, wanting to engage, before this is a full-blown crisis, when so many other players are benefiting from the current system. How do we show this need and have, play the game a little bit?
Well, to change what happens today, we need a lever, we need a fulcrum, we need a place to stand, and we need the power to push down, and we need a hole in reality we can stick the lever into. to move it. We're missing all those things today. And I think we have to fill in each of those 5 elements.
Well, Michael, what do you think? Are we ready for the challenge?
Whoops. Hang on. I am okay. I am off mute. We're here to provide the lever and the fulcrum. That's what our organizing work is designed to do. To provide the lever by helping communities figure out how to provide primary care to more people in this difficult time, and to provide the fulcrum by being organized and using that organization to take on states and eventually the federal government, and convince all those folks to change the world so that everybody has primary care, and use that primary care as an organizing principle to make healthcare affordable again and to improve the public's health. Thank you, Alan, so much for being with us tonight, and talking about these difficult issues. No, not everybody's going to agree on everything, but I think everybody can agree that we are in a state of crisis, and that crisis is getting deeper. And in many ways, that crisis really turns around the withdrawal of primary care from the population as a whole. I loved what you said about having primary care people come back to the hospital. I could do, I have done my own back of the envelope social analysis that makes me think that when primary care people left the hospital, hospitals kind of lost their sense of mission and lost their balance. Your description of what used to happen when people had lunch together is exactly my experience. And it breaks my heart every day to think about what most of us have lost. So thank you again for sort of having everybody take a look at that, even though I'm sure there were lots of surprises in what you had to say.
Michael,
Now,
thank you. Thank you, and thank your colleagues for inviting me.
Well, thank you for coming. To everyone else, I got to tell you that last week in Central Falls, Rhode Island, in a talk that we all did together, sponsored by Primary Care for All Americans and organized by the amazing Carol Rios, someone asked me to tell them what the most important thing they thought we could do today to fix the healthcare mess. And my answer was kind of spontaneous and immediate. I said, let's eat together. And I meant it. When we bring people together and feed them, we're building social connections. And out of those social connections come social movements. And it's going to take a social movement to deal with the huge amount of money that people in the healthcare business have to spend on keeping things the way they are. That's what we need to do now. We need to get together to break bread together and start figuring out what we're going to do next. So don't forget to join us in Cambridge next week, where we'll be breaking bread. We'll be listening to some more amazing people, learning from one another, and building this movement. Now, I'd like to introduce our new executive director, Neda Ashtari, who'll talk about the upcoming inaugural Primary Care for All Americans Health Renaissance Summit, which is going to be held next week on May 20th. Neda?
Yes. So like Dr. Bryan said, the summit is just 1 week away now, and we have 76 people signed up. So we're really excited about it. Just a few details. The audience will be clinicians, members of the community, work group leaders, policymakers, and researchers. We're going to be speaking about where primary care has broken down, but also more focused on the solutions and building a path forward. We're going to hear from local work group leaders about how they've done primary care reports in their communities, how one person or a coalition organized to save a birthing unit in Newport, So we have really inspiring stories. We're also going to honor Senator Cindy Friedman, who is leading policy change within Massachusetts to get primary care to everyone in that state. And Dr. Jonathan Fitzsimon, who a lot of you may have heard, the last speaker that we had, will be our keynote. So we're really excited about that. And he's sharing very interesting statistics and research outcomes from Canada's push to get primary care to everyone. We'll also be honoring Dr. Samuel Shem, and he's the author of House of God and other works about moral integrity in medicine. And we will be honoring him with the PC4AA Samuel Shem Award for Radical Honesty and Moral Courage because of his lifelong willingness to speak out about the dangers of a profit-driven medical system and the importance of really centering humanity and patients in the way that we care for patients. And so if you haven't registered yet, we have about 20 seats open and we would really love to have you there. I put in the chat the registration link. And if there's any financial barriers, please reach out to me. I'll throw my email in the chat as well, and we will find out a way to get you there. We really want people to be able to attend, and we don't want finances to be a barrier. And that's it. But thanks, everyone, and I'm really excited to see a lot of you there.